as an inflammatory cascade gets kick-started, you get all these inflammatory mediators, that cytokines, interleukin, they release. They're all good things. They're all good things in your, but when they are produced in a large number, even your macrophages, even your eosinophils, which are the most beautiful cell of the blood. I call them Aishwarya Rai. Most beautiful cell of the WBC family. Even their friends are enemies. We don't know. Sometimes when they're inflamed, then when they're recruited to the inflammatory zone, they release E protein, which is dangerous. Again, that itself can cause inflammation. So it's a complex mechanism of inflammation. So what are the signs and symptoms? How do a patient with bronchial asthma present to you? Everyone knows they come with cough, wheeze. Wheeze is a very important thing. Wheeze is a medical term. Wheeze means the patient comes and I am hearing my own breath sounds. Wheeze. So it's a musical. What is a wheeze? Wheeze is an abnormal musical breath sound that patient sometimes hear, or sometimes even the family member can hear sometimes if the attack is severe. That is called wheeze. A musical sound of the usually expiration, sometimes inspiration also. So cough, wheeze, breathlessness, and sputum. Sputum production, as I told you, whenever there is a damage, the 100 ml sputum that we produce every day is increasing. So anything extra, any mucus production is more than 100 ml, the body tries to put it out in the form of expectoration. Sputum, phlegm. So how do you diagnose? How do you diagnose? History, of course, I told you, the history of atopy, history of allergy. These people, they may have a history of dermatitis, history of rhinitis, allergic rhinitis, atopic rhinitis, atopic dermatitis. Some people with asthma, if you take the history, they can also give the history of these other things. So usually the episodes are usually early mornings. It is more late night, and around 3 o'clock to 5 o'clock. It is the acute exacerbation of bronchial asthma. Episodes are more common during this time, because during this time your respiratory center is in a depressed mode. So any bronchoconstriction will present like a episode, and suddenly they wake up, suddenly they get up and they rush to a hospital and take some nebulization medicines and all this stuff. And this is a frequent complaint. They have these episodes frequently coming in patients of bronchial asthma. And in auscultation, when you're auscultating, how do you diagnose bronchial asthma? The expiration period is more. When you are auscultating, the inspiration is less and expiration is more. And it is Ronchi. The wheeze that patient is, wheeze is a symptom, Ronchi is a sign. Sometimes we interchange also this, but to be precise, wheeze is used by the patient, and Ronchi we have to auscultate and write in the notes that patient has Ronchi. The Ronchi, the typicality of this bronchial asthma Ronchi is they are polyphonic. Polyphonic means many airways, small, large, many calibration airways are producing this musical sound together. So you get polyphonic ronchi, as if about 6-7 cats are making noise. Sometimes they describe it like a cat's noise. And usually bronchial asthma, these polyphonic ronchi you hear all over. Unlike other diseases where the ronchi is heard only one area, it's monophonic. If there's a monophonic ronchi limited to one area, you think in terms of some other diseases like some tumor or some mass or something. But in bronchial asthma, the typical finding, auscultative finding is polyphonic bilateral ronchi. That is a typical hallmark of the diagnosis. And history is very clear, examination is very clear, and it is a reversible. When you give bronchodilators, patient becomes all right. That is asthma. Again, you have to confirm by doing a lung function test in the form of fractional expiratory volume and all those things. And in the treatment, when you're doing the lung function test to diagnose asthma, you have decreased fractional expiratory volume, and it gets reversed with the small dose of bronchodilator inhaler there. That is the diagnostic. When you send your patient for lung function test, this is the diagnosis, the reversible airway disease, that is asthma. Of course, there are other tests like X-ray. Usually, X-ray is normal in bronchial asthma patients unless there's a coexisting pneumonia or some pleural effusion or some other disease. But if there is no other diseases, it's only pure asthma. X-rays, most of the times it is normal. Even CT scan may be fully normal. Right? What is the treatment of bronchial asthma? The treatment of bronchial asthma can be divided into bronchodilators, and steroids. So in the bronchodilators, we have beta adrenergic agonist, which is most effective. We call it as short-acting beta agonist, SABA, S-A-B-A. Short-acting beta agonist, SABA. We also have long-acting LABA. Those SABA and LABA are the short form that we usually during our discussions in the hospital. In short-acting, we have albuterol and terbutaline, and in long-acting, we have solmetrol and formoterol. So usually we give because short-acting is only short-acting. It acts for only 4 to 6 hours. Long-actings are they last for 10 to 12 hours. So usually we are not using much of SABAs. We use mostly LABAs. So we also have anticholinergics. Anticholinergics like your anti-leukotrienes and theophylline, and we have ipratropium bromide, and in severe asthma you have inhaled steroids and inhaled SABAs, LABAs, and systemic steroids also can be given depending on the patient's response. And if the patient has and one more condition is when patient comes in severe asthma, acute severe, patient is severely dyspneic, then if you put the stethoscope on the lungs, you may not hear any sound. The bronchoconstriction is such a severe extent that we call silent chest. When we call silent chest, that means we are dealing with a acute severe bronchial asthma. So this patient has to be administered high flow oxygen, and many times we may have to put him on ventilator for a couple of days. So that is acute severe asthma. The asthma per se carries a very, very low mortality. But if anybody coming to you in ER with acute severe asthma, if you do not attend immediately and put him on ventilator, you may lose the patient. So mortality is not much, but severe asthmatic attacks, they carry high mortality. So in the treatment, you have to give high flow oxygen, high concentration oxygen, and the SpO2 should be maintained above 90. And this SABAs high dose you have to give, and anticholinergics you have to give. Sometimes we may have to give magnesium, which also helps in the bronchodilation. So in a severe patient not responding,